Hello to everyone. My name is Maria Victoria Mateos. I'm head of the Myeloma and Clinical Trials Unit in the Hematology Department and Professor of Medicine at the University of Salamanca in Spain. And I'm going to present some of the key data from COMy and EHA 2024 on BCMA-targeting agents for multiple myeloma. First, I will focus on some of the data from these congresses relating to the current indications for BCMA-targeting agents in multiple myeloma. I will start with teclistamab, BCMA bispecific monoclonal antibody evaluated in the MajesTEC-1 clinical study, in which this BCMA bispecific monoclonal antibody was evaluated in relapsed refractory myeloma patients after a median of 5 prior lines of therapy. And basically, the common denominator to all these novel BCMA-targeted agents is 77% of the patients included in this study were triple-class refractory. The other important information is the follow-up right now is 30 months, and we've seen that with this update, 2.5 years, the overall response rate was 63%, with a complete response rate or better in approximately 45% of the patients. In terms of outcomes, the median progression-free survival was the same, approximately 1 year, the durability of the response 2 years, and the median overall survival 22 months. With this longer follow-up, no significant changes in terms of safety profile, and neutropenia does continue being the most frequent hematological adverse events. CRS was the most frequent non-hematological adverse event reported in up to 72% of the patients, with no changes with long-term follow-up. Fortunately, infections were very frequent and infections occurred in almost 80% of the patients. However, it's important to note that with this longer follow-up, no new grade 5 COVID-19 treatment-emergent adverse events occurred, and indeed with the transition to the every other week dosing and increasing the use of immunoglobulin replacements, the trend to new infections seems to be decreased. So no significant changes with the long-term follow-up. In terms of efficacy in a specific subgroup of patients, teclistamab has been evaluated in some key subgroup of patients, like patients with high-risk cytogenetic abnormalities, patients with extramedullary disease, patients with high tumor burden. It's important to remark that the efficacy is maintained across some subgroup of patients like those penta-drug refractory with high-risk cytogenetic abnormalities, or even patients older than 75. But it's important to note how patients with high tumor burden, extramedullary disease, or ISS3 reported a efficacy in terms of overall response rate a bit inferior, around 30-40% in comparison with the intent to treat patient population. It's important to remark that in this specific subgroup of patients, although the overall response rate is inferior, the durability of the response in this specific subgroup of patients was comparable to the intent to treat population. Another update that we've seen in these congresses is coming from elranatamab, another BCMA-CP3 monoclonal antibody evaluated again in relapsed refractory myeloma patients, in which basically all patients were triple-class refractory. In terms of efficacy, with additional follow-up, the overall response rate did not change, and it was 61%, with a progression-free survival and median progression-free survival update of 17.2 months and a median overall survival of 24.6 months. In terms of safety profile, no new safety signals were observed with extended follow-up, and in line with what we've seen with teclistamab, the efficacy is basically sustained across the different subgroup of patients, with lower efficacy in patients with specific high-risk features. And if we move on now to the BCMA CAR-T, there were some abstracts focused on cilta-cel evaluated in the CARTITUDE-4 clinical study conducted in relapsed refractory myeloma patients after 1 to 3 prior lines of therapy. And a key inclusion criteria is all patients were refractory to lenalidomide. An abstract also focused on a specific subgroup of patients that we can consider functionally high-risk multiple myeloma. And the meaning of this term applies to those myeloma patients included in cilta-cel after at least 1 prior line of therapy, but relapsing within the first 12 months since the first line of therapy, indicating that these patients are functionally high risk. No significant differences were observed in these functional high-risk patients allocated to cilta-cel or allocated to the standard of care, and approximately 40 patients qualified for functional high risk. And indeed, when these baseline characteristics were compared with those patients included in the CARTITUDE-4 after just 1 prior line of therapy, the baseline characteristics were also quite similar. In terms of efficacy, I would like to remark that the superiority for cilta-cel over the standard of care, dara-PD or PVD, in the CARTITUDE-4 was sustained in patients after 1 prior line of therapy, and equally in patients after 1 prior line of therapy with functional high risk. And this is applicable not only to the overall response rate as well as the complete response rate, but also to the benefit observed in terms of progression-free survival, as well as the minimal residual disease negativity rate, indicating that cilta-cel can represent an option for these functional high-risk patients. In terms of safety profile, no new safety signals, and in line with what we've observed in the intent to treat patient population, it is quite comparable. And another important abstract was focused also on the CARTITUDE-4, but the evaluation of the efficacy of cilta-cel over the standard of care in patients with high-risk cytogenetic abnormalities. And I would like just to note that the definition of high-risk subgroup of patients in the CARTITUDE-4 included the presence of 414, deletion 17p, 1416, as well as a gain amplification of 1q. This definition means that when we evaluate how many patients were considered as high risk in the CARTITUDE-4, 123 and 132 patients in the cilta-cel and the standard of care qualified for high risk. Important to note, as expected, gain amplification of 1q was the most frequent cytogenetic abnormality, followed by deletion 17p, and overall 50% of the patients considered as high risk presented deletion 17p, 414 or 414-16 translocation, that this was the conventional high-risk definition. In terms of efficacy, again, the superiority of cilta-cel over the standard of care was sustained across the different subgroups, and it's important to note how patients with standard risk and high risk allocated to cilta-cel showed similar overall response rate, as well as a similar complete response rate or better, and even in terms of minimal residual disease negativity rate, I would say that it is comparable. So even patients with high-risk cytogenetic abnormalities achieved minimal residual disease negative. In terms of progression-free survival, again, the superiority was always maintained for cilta-cel, and the median PFS overall had not been reached yet, versus 20.6 months for the standard of care standard risk, and the standard of care group of patients with high-risk cytogenetic abnormalities, the median PFS was 10 months, so significantly inferior. However, it's also important to note that when the different specific abnormalities were evaluated, in terms of 414 translocation, the median progression-free survival for cilta-cel had not been reached yet versus 6.7 months for the standard of care, with a hazard ratio of 0.37, and for patients with deletion 17p, the median progression-free survival for cilta-cel was 19.3 months versus 8.7 months for the standard of care, indicating that the benefit for cilta-cel in this specific subgroup of patients is important, although it's true that the median progression-free survival of 20 months maybe is shorter than expected, assuming that we are treating relapsed refractory myeloma patients after at least 1 to 3 prior lines of therapy. I would now like to welcome my co-faculty, Dr. Rakesh Popat from University College London Hospital in the UK, and Professor Evangelos Terpos from the National and Kapodistrian University of Athens in Greece to discuss the clinical implication of this data. So, hello, Evangelos. Hello, Rakesh.
Hi,
and I would like to ask you, point number one, how do you see the update efficacy data presented with teclistamab and elranatamab, the two BCMA bispecific monoclonal antibodies we can use right now in the triple-class refractory population? What are your takeaways? Evangelos, if you want to start.
Thank you, Marivi. I think that the data are amazing. I mean, we have drugs now that we can use it in the triple-class refractory, offering almost 2 years of overall survival. We do know from real-world data that these patients have a maximum of 1 year of survival. So with this drug, we can manage, targeting BCMA, we can manage to have an overall survival of more than 2 years. And the very important thing is that these agents are effective even in patients with high-risk cytogenetics or those who are refractory to lenalidomide. And we do know that these patients are also considered, as you previously mentioned, as functionally high risk, especially if they are progressing within 12 months post-lenalidomide administration. I do believe that the data are extremely good. My main point is that for the triple-class refractory, I have no doubt that these agents are of extreme benefit. The problem is which to use first, because we know that sometimes, for example, for the CAR-Ts, they are not very effective if they are used after the BiTEs or after ADC. So this is my main question, especially for countries that they don't have all the options available.
Thank you very much. Rakesh, do you want to add something? What is your opinion?
Thank you. Yeah, so I agree very much with Evangelos about the efficacy. But if I could bring in the safety that we discussed, I think firstly, it's very reassuring that we aren't seeing any new safety signals with longer term follow-up. So that's a good news. However, what's interesting is, particularly with teclistamab, is that when you move to Q2 dosing, that the infection signal reduces. And I think we were all very, very concerned with the high rates of grade 3-4 infections. Approximately 45 to 50% of patients in Majestic-1 are being hospitalized with an infection. And I think reducing to Q2 and to Q4 dosing is clearly reducing that infection risk, particularly with the addition of IVIG. And I think that really just tells us a new story with these bispecifics, that you can manage them effectively by dose reducing once the patient achieves at least a partial response, reducing again when they achieve a complete response, and you can maintain a good safety profile with that.
Okay, thank you. And just, another question based on cilta-cel. According to the CARTITUDE-4, the label is for relapsed refractory myeloma patients after at least 1 prior line of therapy being refractory to lenalidomide. And you know that majority of the patients included in CARTITUDE-4 were naive for the anti-CD38 monoclonal antibody. So my question for both of you is, considering the sub-analysis we've seen in the functional high-risk subgroup of patients, as well as in patients with high-risk cytogenetic abnormalities, would you use Filtafel in all comers after just one prior line of therapy if the patient is then refractory, or do you prefer to restrict in these functional high-risk patients or in some specific subgroup of patients? Rakesh, do you want to start?
Thank you. Yeah, I think that's a really tough question, Mariví. I think definitely there is now good data for high-risk patients and functionally high-risk patients. As you know, patients who relapse within 12 months, we expect a poor overall survival of probably under 3 years from that point. And we're seeing a very prolonged PFS at this point. So I certainly support that. And even though the PFS for 17p deletion is shorter than one would hope, I still think it's positive comparatively. I think the issue with cilta-cel remains to be the SPM risk, as well as some of the early mortality that we're seeing with some of these patients. And so what I think at first relapse, whilst I would definitely put the high-risk patients in, I would need to have a very careful conversation with the standard risk patients, because they would do very well with Dara-KD or Isa-KD, for example.
Thank you. Evangelos, do you agree or do you want to comment something?
I definitely agree. For the high-risk patients that we don't have good results, definitely, and if cilta-cel is available, it's something that I would take into consideration. But as Rakesh mentioned, for the standard risk patients, I'm not so sure. Without having long-term data, especially for some specific secondary malignancies, the T-cell malignancies that these CAR-Ts may have as a complication.
Okay, so thank you very much for helping me to put in context the latest evidence for the current BCMA-targeting therapy for patients with relapsed refractory multiple myeloma. Thank you. Hello, and we will continue with the new approaches to the use of existing BCMA-targeting agents. I will start by the phase 3 GREEN-H trial, in which belantamab mafodotin has been combined with pomalidomide and dexamethasone and compared with pomalidomide, bortezomib, and dexamethasone in relapsed refractory myeloma patients after at least one prior line of therapy. In this study, the patients included in the study were relapsed and non-refractory after a median of one prior line of therapy. And important to note how the vast majority of the patients were exposed to protease inhibitor, were 100% exposed to lenalidomide, and approximately 80% were refractory to lenalidomide, and 25% of the patients approximately were exposed and refractory to anti-CD38 monoclonal antibody. The primary endpoint was progression-free survival, and the primary endpoint was met in this study. The hazard ratio for PFS was 0.52, median PFS in BELA-PD not reached yet, and 12.7 months in PVD. This benefit in PFS translated also in a benefit in the durability of the response, as well as a clear trend towards a benefit in overall survival. And in terms of quality of the response, the MRD negativity rate was approximately 24% in BELA-PD versus 4.8% in the control arm, pomalidomide, bortezomib, and dexamethasone. In terms of a safety profile, the addition of belantamab to pomalidomide and dexamethasone not resulted in new additional safety profile, and indeed the safety profile was consistent with the known safety profile for each compound. Of note, neutropenia was slightly higher for BELA-PD versus PVD, but also important to note that the patient received treatment for a longer period of time because of the benefit in terms of durability of the response. And maybe the ocular toxicity is the most relevant adverse event to put in context in the treatment with belantamab in combination with pomalidomide and dexamethasone. When we focus on the best corrected visual acuity, it's important to note how 34% of the patients experienced a decline in this visual acuity from 2020, that it is the normal, to 2050. and only 1% of the patients presented a clear worsening with deterioration of the visual acuity to 2200. Important also to remark how the management of this ocular toxicity included dose reductions, dose holds, and with these approaches that were necessary in 83% of the patients for dose holding, 59% for reducing dosing frequency, only 9% of the patients had to discontinue because of ocular toxicity. And this means that the superiority of Bela-PD versus PVD is quite consistent in these relapsed and refractory myeloma patients. And in order to complement this potential new combination, we have also another phase 3 clinical study evaluating also the efficacy of belantamab mafodotin, in this case in combination with bortezomib and dexamethasone, and the control arm was daratumumab, bortezomib and dexamethasone, also in relapsed refractory myeloma patients after at least one prior line of therapy. Well, baseline characteristics of the patients were similar in both arms, and the majority of the patients had received one prior line of therapy, approximately 50%. The majority of the patients were previously exposed to bortezomib. 52% of the patients were previously exposed to lenalidomide, and approximately 1/3 of them were refractory to lenalidomide. Very few patients had been previously treated with daratumumab, but the control arm included dara-VD, and a patient refractory to anti-CD38 monoclonal antibodies were not allowed to be included in the study. At the latest follow-up, 33% of the patients in the Bela-VD arm and 20% of the patients in the dara-VD arm continued on treatment. In terms of efficacy, the primary endpoint was also progression-free survival, and the trial met its primary endpoint. The hazard ratio for PFS was 0.41, and the median progression-free survival for Bela-VD was 36.6 months versus 13.4 months in the control arm for dara-VD. This superiority translated also into a longer durability of the response, and the median durability of the response for Bela-VD was almost 36 months versus 18 months for dara-VD, in spite of approximately 50% of the patients in the Bela arm do continue being evaluated for durability of the response. A positive trend for benefit in Bela-VD in terms of overall survival, and as we've seen for Bela-VD resulted in an MRD negativity rate of 25% versus 9.6% for dara in combination with bortezomib and dexamethasone. In line with what we've seen in the DREAM-8 for Bela-VD, the safety profile was consistent with the known safety profile for each compound, and thrombocytopenia maybe was the most frequent hematological adverse event reported in both arms. But if we focus on the ocular toxicity, you can see how the data are quite similar to what we've seen in the DREAM-7 in terms of best corrected visual acuity worsening. 34% of the patients experienced a worsening to a visual acuity of 20/50 or worse, and only 2% a clear improvement of the visual acuity to 20/200 or worse. And again, as it was reported previously in the DREAM-8, many patients required dose holds or dose reductions, but finally only 9% of the patients had to discontinue because of ocular toxicity. So this information again is consistent and result in a potential new standard of care for relapsed refractory myeloma patients based on this BCMA antibody drug conjugated. In addition, at the European Hematology Association Congress, we had the opportunity to see two specific sub-analyses conducted within the DREAM-7 study. One of them in the population refractory to lenalidomide the other one in patients with high-risk cytogenetic abnormalities. And it's important to see again, point number one, the superiority of Bela-VD versus Dara-VD was consistent in the refractory population as well as in the population with high-risk cytogenetic abnormalities. In the refractory population, the median PFS was 25 months, whilst in Dara-VD, it was only 8.6 months. And this data put in context a poor prognosis for the refractory population. But in terms of PFS in the high-risk cytogenetic abnormalities group of patients, the median PFS in the Bela arm was 33%, quite similar to the median PFS reported in the intent-to-treat patient population. This superiority was also observed in terms of response rate. And we know that quality of life is also important. And another sub-analysis evaluated the quality of life, including vision and functioning measures in the DREAMM-7, and the final conclusion is the quality of life was not different in Bela-VD and Dara-VD, and in spite of the potential ocular events, these adverse events didn't impact in the quality of life of the patient reported in the DREAMM-7 study. If we move again to the BCMA CAR-T, a specific subgroup of patients were presented and treated with cilta-cel. Those patients that didn't achieve an optimal response after first-line therapy, including induction and autologous stem cell transplantation. And cilta-cel was evaluated in 17 patients who didn't achieve at least complete response after autologous stem cell transplantation. These patients had indeed the possibility of continuing with lenalidomide maintenance. The point number one from my point of view is how cilta-cel consolidated very well the response in these patients, and indeed the complete response rate was observed in over 90% of the patients, so it was effective. However, we have to consider the sample size is rather small. In terms of durability of the response, PFS, as well as overall survival, the follow-up is quite short, but at 18 months, over 90% of the patients do maintain the response, maintain alive, and maintain progression-free. No new safety profile were observed, and of course, we need more data in order to consolidate the use of potential BCMA CAR-T like cilta-cel in patients after autologous stem cell transplantation. And in line with this information, another abstract was based on ide-cel, another BCMA CAR-T evaluated in relapsed refractory myeloma patients considered as high risk because definitely they early relapsed after the first line of therapy. In this specific cohort of patients, 31 patients were treated with ide-cel. You can see here the first line of therapy this patient received, and it's important to note how the majority of the patients didn't receive anti-CD38 monoclonal antibody as part of the first line of therapy. Again, ide-cel was effective, and we can see how the earlier use of ide-cel resulted in a complete response rate of 71%, with progression-free survival not reached yet, but at 12 months and at 24 months, well, 70 and 63% of the patients remain alive and progression-free. So we need maybe more data in order to consolidate the earlier use of BCMA CAR-T. Safety profile was consistent with the known safety profile we have for ide-cel in other stage of the disease. I would like to invite once more to Dr. Popat and Dr. Terpos in order to see their experts' perspective on this data. So point number one, I would like to ask both of you, how do you see the data from DREAMM-7 and DREAMM-8? Because this means the use of a BCMA targeted therapy in combination with VD, in combination with PD, in relapsed refractory myeloma patients after at least one prior line of therapy. How do you envision its use in the clinical practice? Evangelos, do you want to start?
Of course. I think that these results are extremely important because I would say that these two studies, if I put the titles, belamaf is coming back, because as you know, belamaf is out of the market in the majority of the countries. And I believe with these two studies, we found that the drug is valuable, but we need to know how to use it. So although in the DREAM7, the schedule of the study was exactly as it was licensed before, 2.5 milligram per kilogram given every 3 weeks, I like extremely the design of the DREAM8 study that after the first cycle, which is every 4 weeks, then we reduce the dose from 2.5 to 1.9 every 4 weeks, and the majority of the patients and the intensity score, they received 1.9 every 8 weeks. So it's one injection every 2 months. So I believe that these two studies will give license to belantamab in 1 till 3 prior lines of therapy. And I think that this is extremely important, especially for patients who progress in DARA-RD, especially if they are progressing in both DARA plus lenalidomide, where Bela-Pom-Dex probably would be the standard of care for this elderly population.
Rakesh?
Thank you. I agree with Evangelos. And just to add that the quality of life data clearly shows that it's quite well tolerated in terms of the regimen. And I certainly find that in my own practice. And if you think about DREAM7, after you finish the first 8 cycles of bortezomib, which is about 6 months, you then go on to belantamab monotherapy as maintenance. And often patients will be receiving the belantamab every 8 to 12 weeks at that stage, as determined by their ocular toxicity. And then this becomes very well tolerated and a very convenient way of maintaining their remission. Whilst the PFS does drop for len refractory patients, I still think it's very good.
Okay, Anna, another question. Based on, if we envision how the BCMA-targeted therapy is evolving, what are your thoughts on sequencing of the BCMA-targeted treatments? So would you have any problem or any concern for the potential prescription of a belantamab-based combination in patients after 1 prior line of therapy based on the future sequencing? Evangelos?
I think this is an important question. And to what I believe is that for patients who are younger, who have high-risk disease, I think that cilta-cel probably is going to be given first. For patients who are elderly, I gave the example of those who progress on after the Maya regimen DARA-RD, while both on DARA and lenalidomide, I think that Bela-Pom-Dex would be the standard of care because the majority of these patients would not be eligible for having a CAR-T product. And I mentioned that because for younger patients, I would prefer to go for CAR-T first because the data that we have, of course, in almost triple-class refractory patients, they suggest that if the patient has received either ADC or bispecific targeting BCMA, and then we give a CAR-T, then the result from this 34-month median PFS, the amazing result of the cilta-cel study, goes down to something between 5 and 10 months, depending on the different studies, suggesting that if we need to use CAR-T, we have to use them first before ADC or a bispecific. That's why I believe that for eligible patients, even if I had a CAR-T product, especially cilta-cel, I would give it first.
Rakesh, please, another very quick question. If you happen to select in the non-CAR-T eligible population, maybe the transplant eligible population, the elderly population, between belantamab-based combination or bispecific monoclonal antibodies that we can imagine that they will come in the future. Any thought about this?
Yeah, it's a great question. I think we talked a little bit about the infection profile with the BCMA bispecifics, and I think that's quite significant. particularly in the older CAR T ineligible population. And I think you have to be very careful. So I think if you have an older, frailer patient where you are concerned about the infections, then I think the belantamab triplet, either with V or POM, is incredible for those patients and will give a very prolonged PFS. I still think that if you do have a younger, fitter patient, then if you can step down with teclistamab and elranatamab to Q2 and Q4 dosing, then the toxicity profile does become better. And then you have, again, a very rapid response and a good durable response. But as you quite rightly say, Maravi, we have to wait for the data to come through at earlier lines with the BCMA bispecifics, because we don't have that yet to come.
Okay, so thank you very much again to both of you for this discussion, especially based on the emerging BCMA-targeting agents for relapsed refractory multiple myeloma. Hello, and now we are going to evaluate the emerging BCMA-targeting agents. And I would like to start with linvoseltamab, another BCMA CD3 bispecific monoclonal antibody evaluated also in relapsed refractory myeloma patients, and 117 patients were included in this study. The majority of the patients were triple-class refractory, 82% of the patients. This bispecific monoclonal antibody is given IV, and when we evaluated the efficacy, the overall response rate is 71%. The complete response rate or better is 46%. According to what we've seen before, the overall response rate is quite comparable in patients with standard risk as well as high-risk cytogenetic abnormalities. And in terms of outcomes, 78% of the patients maintained the response at 1 year, and 69% were alive and progression-free also at 1 year, and 75% of the patients were alive. Something that we've seen, I would say, for all BCMA bispecific monoclonal antibodies, that the responses are quite rapid, and the median time to first response for all of them is of approximately 1 month. In terms of safety profile, I would like to remark that linvoseltamab has been conducted or has been evaluated later on in comparison with teclistamab and elranatamab. This means that the learning process has been important, and when we evaluate the safety profile, maybe we see here how the incidence of grade 3/4 neutropenia was 40%. CRS occurred in 46% of the patients of any grade, but in terms of infections, the incidence of grade 3/4 infection was 34%. But important to note, these patients included in the trial received the adequate prophylaxis as well as the support with IV immunoglobulins. But the data are, of course, encouraging, and I would say that this data can be complemented by the data of ABV3H3, another BCMA bispecific monoclonal antibody evaluated in 220 relapsed refractory myeloma patients. Important to note that this BCMA bispecific monoclonal antibody is also given IV, but in a schedule every 4 weeks and not requiring, in principle, priming doses. The population in which this bispecific monoclonal antibody has been evaluated is in line with what we've previously seen, heavily pretreated myeloma patients, and 81% of the patients were triple-class refractory. As expected, the primary reason for treatment discontinuation has been disease progression, and in terms of efficacy, we see how the overall response rate is 65%, 30% of overall response rate, rapid responses, and the median time to first response, again, 1 month. And in terms of outcomes, the PFS at 12 months was 54.8%, and indeed the median PFS has not been reached yet. And in terms of safety profile, and as the result of the learning curve I previously mentioned, the incidence of grade 3/4 neutropenia was approximately 30%. The CRS was also lower than the CRS reported with teclistamab and elranatamab. Cytokine release syndrome reported with ABV3H3 was 43%, and in all cases was grade 1 and grade 2, with no patients developing grade 3-4 CRS. And ICANS as expected, and as it has been reported for all BCMA bispecific monoclonal antibody, is a very rare adverse event we've seen with the treatment of BCMA bispecific monoclonal antibodies. Now let's move on to evaluate new or emerging BCMA CAR-Ts. And the first one is anito-cel, is a BCMA CAR-T using a D-domain binder, and this means that the sample size is small, and anito-cel has the peculiarity that it can penetrate quite well into the extramedullary disease. We have a preliminary data coming from this phase 1 clinical study in which 38 relapsed refractory myeloma patients were treated with anito-cel. Important to note again, anito-cel was evaluated in heavily pretreated myeloma patients after a median of 4 prior lines of therapy, and 100% of the patients were triple-class refractory. 2 different doses were evaluated, but the recommended phase 2 dose was finally 100 million of CAR-Ts. When we evaluated the efficacy, we can see how the overall response rate was 100%, with the majority of the patients achieving complete response or stringent complete response present in over 80% of the patients. This efficacy, this overall response rate and complete response rate was sustained across the different subgroup of patients, including those with high-risk cytogenetic abnormalities, heavily pretreated, and even patients with extramedullary disease. Sample size is rather small, but this is something that we have not seen with the other BCMA CAR-Ts, even in this heavily pretreated population. Median PFS has not been reached yet, but at 2 years, 56% of the patients remain alive and progression-free. And also, it's relevant the safety profile, quite acceptable, and hematological toxicity as expected. CRS quite frequent, but in all patients grade 1 and grade 2. ICANS very infrequent, and important to note that during the follow-up period, no delayed neurotoxicities have been reported, as well as no Guillain-Barré syndrome, no cranial nerve palsies, and no Parkinsonian-like syndrome. So if we put all data together, it seems that anito-cel is a very effective BCMA CAR-T with also a very acceptable safety profile. But it's true that these are preliminary data evaluated in only 38 patients, and we need, of course, longer follow-up and especially data from the clinical studies that are ongoing with a higher sample size. And another BCMA CAR-T is exa-cel, developed in China and evaluated in newly diagnosed myeloma patients, but with high-risk cytogenetic abnormalities or elevated ISS, and the sample size again included only 16 patients with a median age of 58 years, but according to the inclusion criteria, 25% of the patients presented extramedullary disease, as well as 37% are ISS3 and 100% high-risk cytogenetic abnormalities. And as expected, the most frequent high-risk cytogenetic abnormality was GAIN1Q, and P53 mutation was present in 12.5% of the patients and 414 in over 60% of the patients. 62% of the patients were considered as a double hit and 12.5% triple hit population. exa-cel was effective in these newly diagnosed myeloma patients, again with overall response rate 100% and 94% of complete response or better. In terms of progression-free survival, the median has not been reached yet, but at 1 year, 85% of the patients remain alive and progression-free. Also, we know that after CAR-T, we see deepened responses, and at 12 months, 71.4% of the patients were in minimal residual disease negative. The complete response rate was similar across the different subgroup of patients with the different high-risk features. And also in terms of safety profile, in line with the known safety profile for the BCMA CAR-T, with no new safety signals observed. I would like to invite once more again Rakesh and Evangelos in order to discuss all this data on emerging BCMA-targeted agents. So, Rakesh, Evangelos, hello again. And well, what are the possible implications of these additional BCMA-targeting bispecific antibody treatments in multiple myeloma? Basically, because it's true that ABV3H3 is given every 4 weeks, IV. It's true that with the linvoseltamab and ABV3H3, the CRS is lower, where the index seems to be lower. So how do you see all this data? Rakesh, do you want to start?
Yeah, absolutely. So I think the first thing to say is that I think we're very lucky to have so many different agents under evaluation and development. And I think it just speaks to how effective these drugs are. Having said that, it is useful to have drugs that work in slightly different ways and different mechanisms of action. So I think the fact that ABV383 is given intravenously by a short infusion every 4 weeks without a step up, it makes it quite convenient. We're certainly using it in a clinical trial at the moment, and I'm finding it very effective, and has the luxury of not having the patients coming up once a week to begin with. So I think that's good. And with linvoseltamab, I think we're seeing some very good results and some very good tolerability. But I wonder whether the biggest thing becomes in terms of access, because the more drugs we have available, the competition goes up, and of course it becomes more available for countries outside of the US, and I think that can only be a positive thing.
Evangelos?
I think from what we discussed previously, I believe that the major issue with the anti-BCMA targeted bispecific is the infection. So, and also that we give it every week. Like teclistamab, the patient has to be hospitalized, especially if he has developed the CRS of grade 1 or 2, which is something very common. So I think that if we have something that is given more infrequently, I mean, like every 4 weeks, and if the infection rate is reduced, I think that this makes a difference. From the efficacy point of view, to me, it seems, of course, we have low numbers of patients, not so big follow-up to data for the others, but to me, they seem more or less the same. So I believe that the safety differences are those that will make them more appealing in order to be in clinical practice.
Okay, so thank you. I personally consider that the efficacy for the different BCMA bispecific monoclonal antibodies is not extremely different. So do you plan in the future we will move towards fixed duration of therapy with the BCMA bispecific monoclonal antibodies? And how do you see if we move to fixed duration, this can influence into the treatment sequencing? Evangelos, do you want to start?
I believe that I remember one important sentence of a mentor of ours, Professor Ken Anderson, who mentioned in one of his talks that we need to respect the immune system, possibly with the continuous use of bispecifics. We don't respect it so much. So I believe that the fixed duration is something that we have to test, we have to take into consideration, and if not at the very end of myeloma, definitely in the earlier lines.
I agree.
Rakesh?
Yeah, I completely agree. I think particularly for those standard risk patients, fixed duration, we ought to be considering. And we know that patients are achieving complete responses very early on. And so you can consolidate that and stop. And to answer your second point about sequencing, that tremendously helps sequencing because we have, as we've already discussed, not only BCMA CAR-Ts, but ADCs available as well. And that the fixed duration will allow T-cell recovery, hopefully antigen expression, and allow us to retreat the BCMA target later on down the line. We'd maybe leave a gap and give an alternative therapy, maybe a CELMoD, an IMiD, or a GPRC5D targeted treatment, but we can return to BCMA, which I think will be, in the long run, very beneficial.
Okay, and how do you see these novel BCMA CAR-Ts? Especially, I would like to ask you by anito-cel, because anito-cel is in clinical development in the setting of clinical trials, and the plan is to move to earlier lines of therapy and even to the first line of therapy. Do you see that it is one more BCMA CAR-T, or based on this preliminary data, do you consider that it can be something different? Evangelos?
To be honest, okay, I'm not totally impressed from the data, although they seem better in some categories. We have a small number of patients. We don't have prolonged follow-up. So I believe that it is rather early to have some conclusions on that. I would like to see more data.
I must be, I'm a bit more excited. I mean, for me, the neurological toxicity with cilta-cel is a real consideration. And I think by seeing, even though in a small number of patients, a lack of neurotoxicity, I think makes a big difference.
Okay, and I am going to ask you the last question, because we have now 3 modalities of the BCMA targeting agents, well, and the ADCs that are coming back, as well as the CAR-Ts and the bispecific monoclonal antibodies. Evangelos alluded to the importance for preserving the immune system. And we know that bispecifics as well as CAR-Ts do require from the immune system, but this is not the main mechanism of action for belantamab mafodotin, but it is an advantage in terms of sequencing. But the target for the 3 modalities is the same, BCMA. Do you plan we will evaluate BCMA in the relapsed and refractory setting in order to check if the BCMA is present or not before sequencing these 3 different modalities? Evangelos?
Very difficult question, as you know, because okay, the data suggests that after a BCMA targeted agent, especially if we are using continuous use of bispecifics, it seems that we have very low numbers or absence of BCMA, or at the other point, these molecules are not very good targets anymore because they are having mutations that they don't allow the bispecific to bind there. So we have seen also data suggesting that the use of CAR-Ts after other BCMA are not working very well. So the sequence is a problem. I believe that definitely we need to have a precise time duration for fixed time duration for the majority of these drugs, like the bispecifics and the ADC, in order to leave some more time in the immune system for the reconstitution, and possibly to use another a line of treatment not targeting BCMA before rechallenging.
Okay, Rakesh, do you want to add something?
Yeah, that's a tough one. I mean, I do agree that I think we ought to be testing if you've used a BCMA agent earlier on and you want to retreat them. The question is, what is the best way to do that? Because as Evangelos said, that there are mutations as well as downregulation of antigen. And soluble BCMA is very convenient, but may not give the full answer. So I don't think we've quite figured out the best way of testing yet. And so I think I'll wait until I see some more data, but I think that's the way to move forward.
Okay, so thank you very much for this excellent discussion based on the emerging BCMA targeting agents. I think that we are, I would say, in an excellent timing for the management of relapsed refractory myeloma patients. Many new different options, but I would like to summarize saying that this is a learning process and we need more experience, we need more data in order to plan adequate sequencing of therapies for our relapsed refractory myeloma patients. Thank you very much.